seen reported in the south, and the mortality is very high, 67 to 92%. There was some report 1 to 2 years back, and you must have noticed that. The Hanta virus, Zika virus, I will skip them. Now come to Chikungunya fever. It's the alpha virus, again transmitted by bite of the mosquito, Aedes aegypti. Incubation period is 1 to 12 days, average is 3 days. There's abrupt onset of fever, headache, malaise, abdominal pain. Arthralgia in chikungunya fever is a classical feature. It can involve simultaneously 10 or more joints, and it gives a stooped posture. That's why the name chikungunya has come up from its posture changes. And the wrist joint, tenosynovitis of the wrist joint, is very characteristic joint involvement in the chikungunya fever. Joint fever can last long time. It can be up to 4 months in 33% of the cases, and up to 1 year in 10% of the cases. There can be rash and other things. Neurological complications are so many: encephalopathy, peripheral neuropathy, and GBS syndrome, Guillain-Barré syndrome, myeloneuropathy, myopathy, encephalitis. Comorbid conditions are diabetes, hypertension, coronary artery disease, and congestive heart failure. The typical changes, lab shows low leukocyte, low platelet, CRP is high, serological test you can get IgM very high, and IgG up to 4 times. RT-PCR test is there. There is no definitive treatment for this. Corticosteroid, supportive treatment, paracetamol, or non-steroidal anti-inflammatory drugs. Lassa fever, Congo fever, Ebola fever, there's so many other things, it will take a long time to discuss. I think I will skip those. Now I will come to the protozoal infection, malaria. What has happened in the recent time? There was a very little research in malaria in long time. But recent development have shown some research in this. They have come up with diagnostic biomarkers for Plasmodium falciparum. Histidine-rich protein is detected in urine, and parasite LDH is detected. Hemojoin can be tested, toxic-free heme to hemojoin, aldolase, glutamate dehydrogenase, and haptoglobin. So this is our recent research, and it is being used. The number one HRP2, histidine-rich protein, can be detected in urine, and many of the big hospitals, they are using it. Then there are severity biomarkers. The GGT, gamma glutamyl transferase, LDH, serum bilirubin is increased, and we all know that serum bilirubin, if it is around 3 to or 5, it means there is a severe falciparum malaria. Serum lipase is increased, CPK-MB is also increased. Now, what about the Plasmodium falciparum resistance? The genetic marker have recently been developed to detect the Plasmodium falciparum resistance, and there are so many list of genetic markers, and you can read it. I will not read for you. Now the management portion. They have found that artemisinin based combination therapy is the only answer, because most of the Plasmodium falciparum, they are resistant to artemisinin only. So the artemisinin combination treatment must be given. Examples are artemether, lumefantrine, artesunate mefloquine, artesunate sulfadoxine, pyrimethamine. So the combination treatment only take care of the resistant aspect as far as treatment is concerned. One single drug should not be given. The Plasmodium vivax is also not far behind, and again some research I am just going to mention you. The genetic marker has been developed to detect the resistance of Plasmodium vivax, like mutation at Y976F position. They show the resistance to chloroquine, mefloquine, and artemisinin. There can be complication as well. Plasmodium vivax is not a benign condition. We sometimes think that okay, Plasmodium vivax is all right, but it can lead to respiratory failure, ARDS, and acute kidney injury. Chloroquine resistant Plasmodium vivax management. Again, we should use it ACT combination, artesunate plus mefloquine, like Falciparum. So 2 drugs should be given. Even in the chloroquine sensitive area, there are a lot of the cases have been detected that now they are chloroquine resistant. There is no more benign chloroquine sensitive. Now, the first part of my talk was emerging fever and re-emergence of the fever. I would say that emergence and re-emergence infectious disease have recently threatened our survival and positive health. The list of the disease is too long. It is not possible to discuss all the disease. COVID-19 management has posed real challenge at times, and many times the problem really starts after RT-PCR is negative. 2 examples are very commonly seen is the fever come up after the RT-PCR is negative due to superinfection or co-infection, and the long COVID syndrome. They are really giving lot of trouble to the patient. There is so much of botheration to the doctor, to the patient itself who are suffering. They become psychiatric, they become neurotic, they become economically deprived with the long COVID syndrome. And if you see the incidents, it's a hell of a problem. So now I will come to the second part of my talk. Part 2 is called